do now? Okay. Billing is in the driveway. So this is the SWAT, everybody has access to this. It's basically every single thing. Quick review for nosebleeds. Anterior, the Kessel box plexus comes from the maxillary, facial, and ophthalmic arteries. If direct compression does not work for anterior nosebleeds, and you can see the site of bleeding, then you use the cautery. So it's a silver nitrate bogey. Posterior is the sphenopalatine artery. This requires packing, so you have to start prophylactic antibiotics to prevent toxic shock syndrome. These are different types of keratitises. The bacterial treatment would be antibiotics with or without steroids. If they wear contacts, then you have to add fluoroquinolone. And then biotreatment is just acyclovir. Otitis media, typical if someone had a previous cold. You'd see bulging of the TM, loss of light reflex on exam. The treatment's amoxicillin. And then if they also have conjunctivitis, then you do amoxicillin. Herpes, I feel like this is also kind of derm, but I think the number one that I like to use is valsiclovir. Thanks, guys. Ulcers versus mono. So Dr. Rapani, she said there's 6 letters in ulcers, 4 letters in mono. So the most common pathogen is HHV6, HHV4. Treatment for ulcers is just symptomatic relief, so usually topical corticosteroids or like those ulcer over-the-counter pens. For mono, it's supportive care, but if they test positive for group A strep, then you use penicillin or azithromycin. And then a red flag for patient education that they have to avoid contact sports because of splenomegaly. Really quick ENT, just different things that weren't really like big topics, but I still think that they're pretty important. So it has the treatment for everything. So I think this would be good just to review and know how it presents, the pathogen, and the treatment. Complication of mumps is bronchitis. That's the testicular swelling. There's also blepharitis, I think, but more common bronchitis. Some eye stuff, so knowing pterygium versus puncacula. Someone told me that pterygium looks like a pterodactyl wing going to the eye. So just knowing the treatment for all of those. Alright, these are the exam topics, so it's a little bit longer. So this PowerPoint goes through it. So glaucoma versus acute angle. Acute angle is a more emergent issue. So you see halos around the light, that's kind of the buzzword. And it's painful. So the treatment would be IV versus glaucoma normally is just treated with the latanoprost eye drops. Septal hematoma is a result of a nasal fracture. So it's usually painful swelling, rhinorrhea, congestion. It presents a little bit different than just a nasal fracture. So you need to get a a radiograph if you're concerned for any foreign body, or a CT is more expensive. So if it's like to the eye, you want to check a little bit of the eye. Treatment, you have to drain the hematoma and also put them on Centrelex to prevent toxic shock syndrome again. And then treatment of the nasal fracture is a close reduction. This is blepharitis. This apparently was on the exam, I don't remember this, but it was the treatment. It was the scrub, the lid scrub. So typically you'd see in anterior blepharitis, like the scales that would cling to your eyelashes. And if there's a secondary infection, then you have to use erythromycin antibiotics. Central versus peripheral, and the big thing is just knowing the manifestations. So central is from the brain, peripheral is from the inner ear. So peripheral has a subcategory of BPPV, which is unidirectional nystagmus, versus central is multidirectional. And so central is just treating the underlying cause. And the treatment of the peripheral vertigo is the cannula 3 positioning, so that maneuver. And then there's also symptomatic treatment, like Zofran for nausea. Oh.
Okay, so there's a difference between bacterial and viral sinusitis. So we know that bacterial is the gradient yellow green discharge, and loss of facial pain and pressure. And then the treatment would be NSAIDs for those congestions, and then for viral it's going to be self-limiting and supportive care. And then the difference between the conductive hearing loss and sensory neural hearing loss. So conductive is going to be more so like the outer ear, so auricle, and then the sensory neural is going to be the inner ear, and then they're treated with hearing aid, and then sensory neural, see ears, which is going to be the vertigo, hearing loss, that's going to be treated with thiazide and sodium dye, and then acoustic neuroma, so that's going to be the ice cream cone sign on the MRI, and then treatment would be surgery if symptomatic or large. And then epiglottitis, so that's going to be the 4Ds.
It's at that.
So swelling of the airway, and that'll be the thumbprint sign on the chest X-ray. Treatment, so maintain the airway first, and then advance ICU, hearing antibiotics, and IV corticosteroids for symptoms. And then the sty versus Raytheon, so the sty is going to be tender and it's a blood oil gland. The treatment that would be atrasentan or erythromycin, and then Jillian is the one that's non-tender, and that would just be a warm compress treatment.
So CVRO versus CVRAO. I think the biggest thing is just the buzzwords, so the blood and thunder versus cherry red spot. Because there's no treatment for the vein. Treatment for the artery would be the hyperbaric oxygen chamber. And you need a full stroke workup as well. EMT trauma was something that Griffith said, just be aware of how it happens and the treatment for it. So the acute auricular hematomas, typically you see in wrestlers, you need to drain it as soon as possible. Periorbital cellulitis is usually after like a punch. Same with the lower fracture. So you want to do a CT scan to make sure that there's no lower fracture. TM perforation, systemic antibiotics. If it was from like a water sport, so you want to avoid topical steroids, ototoxic drugs, obviously because it will on the TM and water. Nasal fracture, you want to check for posterior versus anterior epistaxis. And then you do the closed direction that I said earlier. More eye trauma. The foreign bodies, I just know the difference between the conjunctival, intraocular, and corneal abrasion, because they all have different fluorescein stain signs. The ice cream sign is conjunctival. The waterfall effect is in corneal abrasion and globe rupture, and subconjunctival hemorrhage. You refer if it's not flat, meaning that there's worse pictures that I can put on here. This is the flat one. If it's like puffed, the eyes are puffed out, basically you want to refer to an ENT. So now farm. I didn't do a ton of farm just because it was a lot of reviews, a lot of antibiotics. But a big thing was that the MLAs were missed, I think, was something that Griffith said. So these were just the things that in my notes I had highlighted that Dr. Foster said you should know. So scopolamine, that was effective visual and urine. Montelukast, we know that it's neuropsych concerns in kids. Pretty sure that was on the exam today. And then there's just the mnemonics down at the bottom that Foster taught us last semester, I think. And then the third generation cephalosporins, tetracyclines, macrolides, and fluorophenols. So this is the LOAs. I kind of just tried to break it down as simply as possible. From ear, nose, mouth, and throat, and eye. I would just review this on your own if you have any questions regarding the farm. I just want to put this in there because he said that there was a lot of LOAs missed.
Oh yeah, and I put this one in because I feel like not a lot of us are familiar with the iFarm. So for AMD, there's the dry, which is a complement antihistamines agents and antibiotics, so muscarinic antagonists and long-acting antimuscarinics. And I think these next two were questions from the exam. So tacrolimus increases the outflow through the scleral pathway, and then taxanol increases aqueous humor and it's safe for pulmonary disorders.
This was something that Foster gave at her lecture, it's just the word association, so toxicities, notables, high yields, and contraindications that you can look at if you want. Et cetera. So first generation antihistamines, remember they're more sedating. The less sedating drug that's used for vertigo is meclizine. The mast cell stabilizer for allergic rhinitis is metoclopramide. Rhinitis medicamentosa is from nasal decongestant overuse. And then if someone has allergic rhinitis and is poorly controlled with intranasal corticosteroids, then they need immunotherapy. Here's some buzzwords. So, Sandra's triad, it's ANA, so aspirin sensitivity, nasal polyps, and asthma. These are just a couple buzzwords that were through the slide, and also some extra ones that are just known. And there's SAD treatment used for peritonsillar abscess, so it's supportive care of antibiotics and drainage. These are the 4 Ts, so you want to think epiglottitis or rochopharyngeal abscess. So it's dysphagia, drooling, dystonia, so the muffled hot potato voice, that's more common in RPA, and then distress. Moat is for sinusitis, or rhinosinusitis, so it's mucosal edema, opacification, air fluid level, and thick secretions. Fail, I've also seen it as fake. Lack of cough is spelled with a K, but fever, adenopathy, lack of cough, it exudates, and then there's a point system. So 0 point is low risk. If they get higher points, then you need